Thank you and good morning. I think it's near to good morning and a good afternoon. I am Dr. Bhrigu Kapuria, and we are part of the Ministry of Health. We are a special unit created at the Ministry of Health to support the immunization program. And therefore, I will talk in a bigger context of immunization. And I'm here to present you a small work that we have done to streamline the vaccine logistics management system in the country. It's a model that we have developed, and the model is called as EVIN, and I'll come to the details of what EVIN, but just to give you a background, India conducts one of the largest immunization programs in the world. We have got a target of vaccinating 26 million newborns, children, and 30 million pregnant mothers every year. This totals to around more than 300 million doses of various antigens. And this is routine immunization. I'm not talking about campaigns. So considering this magnitude, we have got a 5-tier vaccine supply system. Actually, the first tier is buffer storage space and a 4-tier supply system. The supply from upper nodes to the lower nodes happen in my country due to various reasons. It could be stockouts, it could be stock availability, it could be monthly targets, on a variety of factors. If you look into the entire picture as a country, it varies from district to district. And one of the big reasons for this variability is lack of visibility. We have coined up a term called as a coal mine effect, because you can plan only till the time you can see. And so planning happens only in light areas. And so each planning is different. And therefore, you can't link upon different plannings. To look in what is the end-to-end problem, ITSU, the short form of Immunization Technical Support Unit, conducted a deep dive assessment to look in end-to-end problems. What are the reasons for non-vaccine availability? Just to give a background, one of the major reasons of children missing out full immunization is non-availability of vaccine session sites. So the crux of the deep dive assessments gave in 3 basic crux. First is lack of stock visibility, lack of human resource management, and poor stock keeping. To follow up this action, we looked into a feasibility study where we looked in how can private sector be involved into better logistics management. This entire work led us to 3 models. The first model was to strengthen the existing system with better tools and technologies. The second was to take away the system and outsource it to private sector using the same health facilities. And the third model was to totally outsource, even the cold chain equipments get used by the private sector. So all the 3 models were reviewed by Government of India, and there were various factors that were reviewed in, which are the feasibility and sustainability, cost versus benefit, impact on the existing system. And finally, Government of India decided to look in for the model number 1. So ITSU was asked to develop a model on the outlines of model 1, and they positioned us 3 questions. The 3 basic questions were, they want to know, where are my vaccines? The second was, are they in adequate quantities? And the third is, are they stored under recommended temperatures? So if you ensure these 3 fundamental questions, you can ensure that your vaccines are reaching at the end point in a right condition, in a right quantity. So ITSU designed a model called as Electronic Vaccine Intelligence Network. In short, it's called the EVIN model, to answer these fundamental questions. We have 3 components in this model. And again, just to clarify, this is not a system, it's a model which has components. So it is designed in such a format that you can, if you apply these puzzles together, you can use this model anywhere in the world. So the first component was people, that is the human resource, especially for vaccine logistics management. The second was streamlining processes in the thing. And the third was using appropriate technologies. This is an overall system design. I won't go into the details, but you can. We created some basic fundamental principles while designing the model. We said the model should be replicable. It should not be a model which is piloted in a controlled setting and then cannot be replicated. It should be expandable, and it should be self-sustainable. So the entire model is built upon a built, operate, and transfer technology. Once this model was developed, it was thought that, does this model works? And to check out whether the model works or not, we brought this model onto the field settings, and we took in areas which were the lowest immunization coverages to try it out in the resource poor setting. Does that work or not? The second criteria for choosing areas was, it should be a representative sample. It should not be a very small population where we take in, demonstrate a model. And so that kind of model implementation was taken. So we took 2 districts in one of the largest states of India, called Uttar Pradesh. We took in Bareilly and Shahjahanpur districts. Bareilly had a full immunization coverage of 41%, and Shahjahanpur had a full immunization coverage of 28%. So And to give you the district profiles, these two districts have a total population of 7.4 million, which itself is a large enough population, more than had around 200,000 newborns for vaccination every year, around 240,000 pregnant mothers. In all, if you total for all age groups, it is 1.1 million children that were eligible for vaccination every year. So it's a large sample size that we took in. The first thing, so when I talk about people, process, and product, the first thing that we did was removed non-standardized procedures. So these were the registers that were used. We brought in standardization. The good part is that at this point of time, Government of India adopted these standardized models for the entire country. So what you see from the pilot is now part of the entire country program. The second and the most important component that we talked about was people. So we created a cadre of people called as vaccine and cold chain managers. In short, a VCCM. A VCCM was located at the district. So for 2 pilot districts, 2 VCCMs were given. These VCCMs are under direct support for the district immunization officer. So just to give you a background, the district immunization officer is the only person in the district who takes care of immunization, and he takes care of how the program runs, who runs the program, where the vaccines come from. And the sad part is, in most of the districts, they also hold additional charges. So he's also the malaria officer, he's also the TB officer, he's also the court case officer, he's also doing so many things. So he practically doesn't have time to do logistics management. So we stressed upon a point that he needs support by a person who can actually handle vaccine logistics, inform him, help him manage. That was the criteria to develop him. We also brought in that the vaccine logistics manager will not only do a management, he will also act as a supportive supervisory tool. He will build in the capacity of health workers who are handling vaccines. In my country, vaccines are handled by auxiliary nurse, midwives, the ANMs. These are the nurses who handle, and so they are not trained properly or trained very professionally on vaccine logistics management. So what we decided was, let's build upon the vaccine logistics manager to do a supportive supervision for these guys also. The third thing that was very important was sustainability. In large number of pilots that happen in the country, you hire a person on such a salary that once it comes to the government says, oh no, I can't take that. So we decided that anybody that we hire upon will be in parallel with the government salary structures, so that absorption and retention becomes possible. The fourth and the foremost vision that we have been talking yesterday also is, so because we are working on the immunization, so this is primarily a vaccine logistics cold chain manager, but the entire position has been developed with a bigger aim to have as a health logistics manager for the districts who can handle drugs, who can handle other commodities related to public health in the coming time. The third component of EVIN system is technology. And we used appropriate technology. So the word appropriate is very important technology, because using inappropriate technologies has led to downfalls in many LMIS systems. So we designed our system which works upon mobile technologies and computer-based technologies. In India, the advantage of technology comes with mobiles. We have more than 800 million mobile users. So practically every adult is using a mobile. And they know how to use a mobile. So we leveraged upon that point. We said, you know how to use a mobile, let's give them a mobile and let them use that. We also took care that mobiles, my frontline health workers are not equipped of using a smartphone, a touch screen. So we restricted ourselves to basic Java phones. And we applied basic technologies at field level, and we applied computer-based technologies at district and above level. So an appropriate technology selection, if you see into the slides, the district store works on a computer, whereas all the lower peripheral stores works on mobile technology. These all components were merged together to bring in some expected results. The expected results were improve availability of stock availability, real-time data visibility. There should be tools for managers to use that, strengthen out the entire health system. So the entire concept of EVIN is built upon health system strengthening, and then a model that can be replicated in the entire country. The initial results were very encouraging. If you see, the EVIN system has managed to have vaccine availability at 99% of places, availability of vaccines, visibility at more than 90% of places. Stock out rates have gone down drastically, and I'll share you some more details about the slides. If you look into the reporting pattern has been nearly 90% in both the districts over the period of time. We also looked in whether the reporting is fine, but is it a complete reporting? And so if you look again to the completeness of reporting, it's again a 90% of completeness of reporting. We looked into the stock out situations, which earlier period during the start of the period was nearly 70% of cold chain points reported stock out, which has now gone to less than 10%. The key lesson learned. So the key lessons that we learned and that we are propagating everywhere is that with only technology, you cannot work. With only human resource, with no better tools, you cannot work. But marrying appropriate human resource with appropriate technology, you can have better results. So you need to have a system which says appropriate human resource with appropriate technology and appropriate tools to work, and then you can run in. The EVN results in my country has shown very promising results. The Government of India has already started thinking of scaling. In the next steps that we talk about is the EVIN concept has been taken up as the national concept for vaccine logistics management in India. This is now being scaled up to the 3 largest states of the country, totaling to a population of 345 million people. So starting November, EVIN will be available in 3 bigger states of 170 districts with 345 million people. And a position of VCCM at every district is being considered by Government of India. So the model has actually brought in a platform where you can demonstrate and advocate for an appropriate human resource to be positioned. What is the advantage of positioning an appropriate human resource? To conclude, and I'll stress upon the point number 2, is to advise that characteristic of EVN model is built upon a strong network. So what we believe in developing and in middle and low income countries is that if you bring in human resources, if you bring in appropriate technologies, and if you bring in process standardization, you can actually do better logistics management, whether it's vaccines, whether it's drugs, whether it's anything else in public health settings. Thank you.